A recorder joined.
Great, thank you.
So this is an overview of what this presentation will look like. So we'll first start with the Latino HIV Initiative, which was from HRSA, and it was a federally funded.
Joined.
Jada Cardone.
Joined.
And then we'll talk more specifically about HIV in
Joined.
North Carolina, Latinx community, talk a little bit about our background, preliminary and formative research, our intervention itself, sort of the model that we used to approach this by working collaboratively with the community, and then our own perspectives. Next slide. So the HRSA SPINS Latino HIV Initiative, it's sort of a subheading of the culturally appropriate interventions of outreach, access, and retention among Latinx populations. So nationally, this was a 5-year project from 2013 to 2018. So we just closed enrollment in August. This last year is used to finish out our sessions and our interactions with our clients over a 6-month period, and then transition them to long-term case management care, and then do all of our research, our findings, our publications, and that sort of thing. There were 10 demonstration sites across the U.S., mostly in large cities, so LA, New York, Chicago, Dallas, and a few others. So each site got to determine their target subpopulations, whether that was MSM, that was enablement, and what that looked like for their site, and also country of origin. So of the 10 sites, I think it's equally split between Puerto Rican and Mexican, depending on the demographic of of HIV in their area. And each site got to sort of design, implement, and evaluate their own program. So what approach did they want to take to increasing identification, linkage, and engagement into care for their population? And this was grounded in a transnational foundation. And I'll go into a little bit more in depth in that in the next slide. So for North Carolina, we're the only sort of site in the South, if you don't count Texas. We are the only sort of statewide site. Every other site was based in a large urban city. We have sort of 2 metropolitan areas we operate out of, though our reach is a little bit broader, but mostly Raleigh, Durham, Chapel Hill, and then Charlotte. And we partnered with 2 community organizations, El Centro Hispano in Durham, which is a grassroots nonprofit community organization, and then the Regional AIDS Interfaith Network in Charlotte, which is mostly a case management agency, and they also do education and advocacy. Next slide. So this transnational approach, so it's really looking at an individual's life holistically in terms of the majority of our clients are migrants, are undocumented, and the transnational approach really thinks about the link between their country of origin and their place of settlement, and also the links or like places they've reached or settled in before where they're residing now. So whether they came to Texas and then went to Georgia and then came to North Carolina, but really about having these 2 large social networks, sometimes dual lives that we've seen in our clients' lives. Of some of our clients came here for work or to live more authentically, to live openly, and so that makes a difference in their lives. And how do you approach that or approach their health care with the context of their lives, of living separate lives often, leaving behind social support, or maybe leaving behind stressors depending on their life situation, and settling into a new area where they may not know anyone, or have trouble finding community, or sometimes have to live in the shadows again. And so that's kind of what that approach is really thinking about the whole context of their lives. Next slide. This goes a little bit more in depth. So all the different factors into these transnational lives. So it's family, it's finances, it's social, it's religious, it's politics. Again, those social networks that they have, one large social network in their country of origin, and another one in the U.S., and for us particularly in North Carolina. And we do have some clients that were born in the U.S., so really thinking about the lives of their families as well. What does that look like sometimes their families are undocumented, are traveling back and forth, or what does it mean to have a cultural background and be separate from the country of your family and yourself as well. Next slide. And So really, the transnational lives function as a cultural point of reference, sources of information, emotional and practical support. So sometimes they have two networks of families, in Mexico and North Carolina. But that can also be two different sources of discrimination and stigma, especially if they're living these different lives. Also sources of belief about health. Healthcare is very different in Mexico compared to North Carolina or the U.S. broadly. Some people have terrible experiences both in the U.S. or in Mexico or vice versa. And so again, you have sometimes conflicting ideas, conflicting experiences, depending on where you're coming from, where you're living, and then also your access to healthcare and practices. Next slide. So specifically in North Carolina, we're going to talk more about what HIV looks like for us here in the Latinx community, and what sort of we use to approach our own structure of our intervention. Next slide. So from 2004 to 2016, the Latinx population in North Carolina increased by 84%. And before that, from 1990 to 2000, it increased almost 400%. So you've seen huge growth in North Carolina for the Latinx community, and largely that's been immigrants and foreign-born Latinx residents. And so we have what we've seen in our own client population is mostly immigrants, mostly undocumented, mostly monolingual Spanish-speaking. So how do you approach healthcare with the community in ways that they can access it, they can have, and also receive quality healthcare? So we have to approach our intervention with all of this in mind. And also in North Carolina, the Latinx community is making up a larger portion of newly diagnosed cases. So in 1995, they made up 1%. In 2009, it had jumped to 8%. And in 2016, now it's 10.5% of all newly diagnosed cases, while representing only 9.2% of the statewide population. So there has been a steady increase, and we know we see that also on a national scale, and it is being reflected in North Carolina as well. Next slide. And in North Carolina, and this was some of the research also used coming into our initiative, was the Latinx community had the highest proportion of late testing cases, so very large, 38.5%, many of them being diagnosed with AIDS at the same time or with co-complications. Again, we see that reflected in our own client population. And the highest proportion of unmet needs, so no care in the last 12 months. So very much, very sort of dire issues that we needed to address, things that should not be happening. So we needed to think about what is causing these late testing cases, why are they not engaging in care when we do have these services or resources. So what are all these gaps we need to fill? And I put these two images here. The top one is people diagnosed with HIV in North Carolina, not broken down by race or ethnicity. And then the bottom is the Latinx population. So you can see, where HIV is largely also where the Latinx population is. So I just wanted to use that as kind of a comparison to see that they are overlapping. And you think about, HIV being part of your social and sexual networks, geographic areas matter, and so we see that those overlapping, where HIV is also is where the Latinx community is as well in North Carolina. Next slide. So this was some of the research used to approach the structure of our intervention. These were studies done prior to the development and also used to apply for this funding. And so this first one on the left, there was 127 Latinx individuals interviewed in North Carolina who were receiving HIV care. Of those, 104 were immigrants, so again, a very large portion, 23 are U.S. born. And of the immigrants, 90% received HIV diagnosis in the U.S., 36 diagnosed within 5 years of migration, 91% uninsured, and 82% monolingual Spanish speakers. And as you see in the very bottom, they had a lower median CD4 count. So again, this is very much reflected in our own client population, that largely immigrants, largely uninsured, monolingual Spanish speaking, and are entering care with a very low CD4 count. So again, going into this, so what are the factors, what's causing this to happen, or something we kept in mind approaching the development of our intervention. And then on the right is a study done that Lisa was also the PI of. This was Young HIV-Positive MSM of Color, Project Style. So this was Black and Latinx individuals. So again, you see, large gaps in care, but with it, they also use a navigator model, and you see that there was a very high retention in care. So we know that this model works. This is something we also implemented in Enlaces, and so we wanted to use these same approaches. We knew it works. We knew that we have lots of gaps to address. And I don't know if you want to add anything to that, Lisa.
Yeah, sure. So I think in thinking about Enlaces, when we applied for this SPINS project, I think one of the really lovely things about SPINS in terms of as sort of a research framework is that it really is focused on research that is can be translated into care and into sort of practical implementation to have an actual impact on the target population, which is rewarding when you find something that works. So for Style, which was with our young MSM of color, we realized that it was really important for these youth to have someone help them navigate the system. And again, a lot of the challenges for these youth were individual and psychosocial and related to stigma and other barriers, individual level barriers, but a lot were structural in terms of transportation or navigating a complex healthcare system. And so we translated a lot of those findings when we applied for this grant for Enlaces, which was also a SPINS grant, to try and develop a sort of a culturally relevant intervention grounded in sort of the transnational framework, but that addressed not only individual but structural barriers to care for the population of interest for us, which was Mexican men and transgender women with HIV in North Carolina.
Next slide. So there's a couple more. Yes?
It sounded like someone was joining.
Oh, okay. A couple more formative research sort of pilot studies that were done that we also used when developing Enlaces. So life histories of Mexican men living with HIV in North Carolina, and Lisa was also involved in that. So 15 men interviewed, multiple time points. So there's also a building of rapport there of trust, really trying to get through to what we're experiencing like when being tested for HIV, and all of the people that were interviewed had delayed testing or only tested when they had serious complications. And so what they found through those interviews was things we've seen before. So fear of results, HIV stigma, lack of knowledge about HIV and testing, limited access to health services. And this definitely transfers into care and the way they are able to process, their diagnosis, process the ability to navigate their own care, and again, what we're seeing in our own client population. Many of our individuals that we've enrolled in our program have said, I thought I could have HIV, or it didn't surprise me, but I did not want to confront that reality, or I didn't want to have to carry that burden. I didn't know if I could ever share that with people, so there was that conscious delay of testing because of these reasons. And that definitely impacts their care after diagnosis. And so there was also formative interviews with Latinx individuals in care in Charlotte and Chapel Hill, and this was done prior to the launch of Enlaces, and done in our 2 target areas to also really delve a little bit deeper into their care. Since we looked at testing, we wanted to look at care. And what we found was after diagnosis, their sort of desire to go back home changed drastically. A lot of them said they could never return home, that they had to continue out their life here in the U.S., and there was definitely this feeling of being cut off from family, from friends, of the ability to have even choice or ownership over where their life was going to lead after their diagnosis. And so these disclosure and stigma fears exist both in the U.S. of not wanting to share it with their social and sexual networks here, not wanting to share back home, and not being able to return home. And that was a very common theme we found. And also in these formative interviews, there was very much an emphasis on case managers about even when they felt like they had a handle on care, about how to schedule appointments, how to pick up their meds, what CD4 and viral loads meant, individuals were still going out of their way to find a case manager because they just needed someone on their side, someone to have support. So we did realize that this individual is key even after, feeling very much in control of their care. Okay. Next slide. And so now we'll delve into our intervention itself. So this is the staff. So Christina on the left, she's there with me. She's one of our outreach people at El Centro Hispano. In the middle, there is Roberto and Aleida at RAIN, and they were talking on a Spanish radio show down in Charlotte about Enlaces. And they did this every few months to sort of talk about what the program is, the resources, and also took calls. And people were very responsive to it. It got a lot of traction. People were very interested, and allowed people very much a safe space to call anonymously and ask these questions. And they also saw people coming into RAIN the next week looking for testing because they heard about it on the show. So that was another very powerful way to spread the word and use sort of an alternative mode of communication to talk about Enlaces. And Maritza's here. She would use this banner at different health fairs. This actually was at a club night that she went to. And then here's Aleida at the AIDS walk, supporting the Enlaces here as well. So these are our navigators and our outreach staff here. Next slide. So the structure, we enrolled newly diagnosed or out of care or inconsistently in care Mexican men and Mexican transgender women. We initially did start with MSM, but we chose to shift that because we realized that, that is not something people are going to disclose right away. You need to build up trust, and if we're going to start with MSM, we're potentially excluding a large portion of the population who could be receiving the services. And we did see that as, even after months of interaction with the navigator, the client would disclose, oh yes, I'm gay or bisexual, or I had sex with men. And so it took a long time to build up that communication and that trust. So we chose to expand our criteria to allow for more people to benefit, and I think that was a huge part of our success as well. And also, we chose to go also inconsistently in care, not just this very strict out-of-care model, because people were also relying on walk-in clinics, were canceling and rescheduling appointments often, and so we felt that that wasn't very reflective of true engagement in care. And so we also wanted to bring those people into the fold and say there are issues going on in these people's lives that they could benefit from the resources, and we wanted to allow the opportunities for them to be enrolled and participate. So we expanded both of those criteria. And so we have personal health navigators, they're both bilingual. You have Maritza and Aleida from the previous slide, one in Durham, one in Charlotte, out of our community partner sites. They're trained in strength-based counseling, and they work one-on-one with clients to either connect or re-engage them in care, link to support services, and we design a 6-session curriculum sort of delivered over the course of 6 months according to the client's schedule. And I think a big part of that success was that one-on-one model of having, that space to talk openly and really build up that connection. And we saw that definitely pay off over the course of the intervention. And our sort of intervention goal was health self-management. So really trying to empower the clients. It wasn't just about what does your CD4 and viral load mean. It was about teaching them how do you cancel and reschedule appointments, how do you pick up your prescriptions, how do you make sure you have enough if you're going to be traveling out of the state for a few months at a time for work, how do you get in contact with your doctor. Some of our clients, clinics were leaving voicemails on their phone. They didn't even know how to check their voicemails, and these are things that were being overlooked. And so the navigators really got to talk to them and figure out, okay, what are these skills? Also learning the bus system and things like that. We talked about structural barriers, and so learning the bus system, how to get monthly passes, how to get discounted passes. And so there are different sort of tactics the navigators use with each client depending on their case and their care.
Joined.
To work with them and engage them in care. And the goal was, after these 6 months that they wouldn't need the navigator, that, they would transition to long-term case management depending on where they were getting care, but they wouldn't need the same intensity that the navigator was providing during these 6 months. Next slide. So our team structure, so we have the sort of research team at UNC, we're the PI and co-PIs, qualitative and quantitative evaluators, and myself, the project coordinator. And then El Centro Hispano, we have the personal health navigator, an outreach staff member, and then the same structure at RAIN. And I think one thing that we've talked about as a team and also in, among the other sites is one thing that I think really was successful is that our research team and our community site team represented collectively our entire client population. There are Mexican and Mexican Americans on staff, immigrants, HIV-positive, gay, and transgender individuals. So there were times that, someone's working with a client that maybe doesn't know how to address certain issues or needs a little bit more support talking about it and would turn to another team member. And we're able to really work collaboratively as a team to think about what is best for our clients and bring our own sort of life insights to that. I think that was a great model. Next slide. So a little bit of our intervention sessions and sort of this transnational foundation. So session 1 was, introduction to the program and also the client background. And so we talked about migration history and any relevant experiences that may shape their HIV care, especially if they were newly diagnosed or out of care. Those were 2 very different tracks. So the navigator would have to approach those very differently depending, why did they fall out of care, or if they were newly diagnosed, how did they get in contact with the navigator? What was that referral system like? How were they dealing with their diagnosis? And the migration history really laid a foundation for that relationship to build over the course of those 6 months and beyond. And so really one of the first things, in those sessions that the navigator asked the client is, tell me your story. And people were very open and shared a lot, and I think and they would even say, no one's ever asked me these questions before. And that was really important going into this, is thinking about what do they want to share, what do they feel comfortable sharing, and how does that impact their care. And a lot of it is tied to their culture background, where they're coming from, these dual lives that they're often living. And so this was definitely something that would continue to expand upon over the course of these 6 sessions. And so session 2 is medical care. So they do talk about more in depth the diagnosis, the CD4, the viral load, and things about what happened in your care visits. Do you have questions? How do you communicate with your team? How do you identify, support people on the clinic staff? And a lot of that also with healthcare history and beliefs, not just related to HIV, but if they had received healthcare here in the U.S., were they good experiences, were they bad experiences? What worked, what didn't, and some of our clients have received HIV care in Mexico, so also what did that mean for their care here? Or some people had never been to, formal medical care like they did here once they were HIV diagnosed, and this was one of their first true medical care visits was after they were diagnosed. So that greatly impacted their engagement in their care. So asking these questions, knowing they felt we had I know a client who was very, very resistant to any sort of medication, and that was something he carried from his family. And so these were very important conversations to have, and this allowed the space to ask them to discuss them in ways that were not sort of targeted or attacked, but just say, I want to learn more about you, about what have been your experiences, what are your beliefs. And session 3 is social support, so really talking about the people in their lives, both positive, maybe negative, in Mexico, in the U.S., as sources of support, especially related to their HIV, their gender, and their sexuality. So they're open to some, not open to others. Some people knew about their diagnosis, others didn't. Some people knew about their sexuality and gender, but not their HIV. So there are a lot of different layers there. So knowing who are the people who are in their lives matter. If they're having some personal issues, who can they turn to? And so this was, again, building upon that relationship with the navigator and the client. The next session was stigma and disclosure. In this session, the clients got to sort of role play with the navigators disclosing to people who they wanted to in their lives. So that built upon the social network inventory. So these are the important people in their lives. Are there people who don't know about their status? Do they want to disclose? And they would sort of practice what that looked like. Where is it safe? How would this look like? What is the language you want to use? What could be the outcome of this? And so, again, safe spaces to really practice this between the navigator and themselves. And also talking deeper about stigma and discrimination, and not just related to HIV and gender, but being an immigrant, being undocumented, being a monolingual Spanish speaker, their occupation. And so lots of different sources of stress in their life as well that, again, impact their health care. Session 5 was healthy living, mental, physical, spiritual health, also medication adherence, but nutrition, and depending on the client, they would also talk about sort of substance use in this session too. So, and addressing those accordingly, helping them get support services, and talking about stress or what kind of things in their life are they doing to offset some of the stress as well. And then Session 6 is built around health self-management and sort of transition out of the intensive navigator-client relationship. And also they talk about their future in regards to relationships, treatment, migration. So if they do want to return home, what does that look like? Getting resources for HIV care in Mexico, making sure that they do have options and talking them through that if they have the desire to return, or talking about relationships. We had some clients who then of this felt like, oh, I can actually have sexual relationships again, because some people felt very much cut off from that after their diagnosis, and also ways to continue engaging in care. Next slide. So why did we take this model? And we'll sort of go into the next slide will be sort of, the benefits from both sides. What do we offer each other? And I think that's the important, is that we all have something to offer each other. What does that look like in our instance? Next slide. So from a research standpoint, from UNC, we are a large institution. We have, like Lisa, as a PI, comes in with a lot of experience of these studies of being a clinical provider as well, not just a researcher. And as an institution in UNC, we have a lot of resources to offer community-based organizations. We also have lots of contacts. We have relationships built with clinical providers and healthcare staff. We have state HIV staff, like the disease intervention specialists that we work very closely with, or state bridge counselors. We also had access to clinic out-of-care lists. And these are sort of things that may have been possible to work through as a community organization, but it would have taken a much longer time and been much more difficult. So one of the ways we did get referrals for our program was at UNC in the Wake County Health Department. We were able to run out-of-care lists and sort of filter through for people who qualify for a program and then reach out to them personally. And this was because we are a research institution, because we have providers on staff and able to have that trust built in, and that benefits the program overall, and we're able to use those handoffs to our to our navigators. We also had access to state-level medical record systems like CareWare. We were able to build our own sort of Enlaces domain within CareWare that we can house all of our clients, have one place to go to update their medical records, to see what's happening. Again, a very big benefit to being a research institution. And we were able to provide capacity building resources, able to provide funds for the LGBTQ support groups at El Centro and at RAIN to build some of that capacity as well. Bring the navigators to some of our meetings, to do trainings, and really share this wealth of resources we have. And from a community standpoint, El Centro and RAIN, they have these long-standing reputations in the community. They are housing the community. This is the community itself, the people who work there, the people they serve. And so there is immediate community buy-in. There's a deep level of trust there that, people don't trust researchers all the time for very good reasons. They don't trust research institutions. And so having this system of working collaboratively with the community organizations is really important, because you're not coming in saying you know everything. You're allowing the community to dictate what works, what doesn't, how to approach the community. And our staff was representative of the clients as immigrants, as members of the LGBTQ community, as HIV-positive individuals. Again, this community buy-in of being a familiar face, not a researcher, was very, very important. And then along the way, as we sort of come in with, Lisa and other researchers with the experience of this is the way the studies go, this is the way we need to, write reports for HRSA and things like that. We also need staff and community input as to what does work. Going through, we did long trainings and meetings where we read through multiple times our sessions. Some of this language doesn't work. There are lots of intricacies of language, of Spanish itself. Some was too clinical. Some was too this high-level education that is not going to transfer well to having this personal relationship with the client. There are certain specifics to Spanish in Mexico versus Spanish in other countries. So we're able to, as a staff, go through the curriculum and really tailor it to our community. And so, like, this is what works. And so I think we all have something to offer in terms of, research and resources and institutional connections in the community. Organizations is the community. We need that buy-in. We need them to tell us, this is how you need to approach this. This is what our community needs. This is what works. And sort of go back and forth and hold each other accountable in those ways. Next slide. So these are some of our larger outcomes, and I think in successes and challenges. So I think one of our biggest successes was that our navigators were both immigrants and both Latinas, and that was a big theme that came out over and over and over again with our clients and from the navigators themselves, that having that connection of knowing what it's like to be apart from your family, to be cut off, to have to communicate only through phone, to not be able to visit, was an immediate connection with the clients, of being familiar. You didn't have to guess. You weren't an outsider. And that made a wealth of difference in the clients' lives and their ability to really engage and trust and share with the navigators that ultimately improve their healthcare engagement. At RAIN, so the Enlaces clients showed that they had the highest retention of all of their case management programs, which is a huge success.
I didn't know that.
Yeah. Chelsea
I'm hearing that.
Chelsea told me. Yeah, so, I mean, really, she asked me, so what's so special about Enlaces? She would, the supervisor at RAIN, she's the one that told me, Enlaces clients have the highest retention out of all of our clients at our agency. What is it? And then it was really about that one-on-one connection of having space to just talk about your lives, that it's not just your HIV diagnosis. That's not who you are. It's about the whole context of who you are as a full individual. And those were the conversations our navigators are having with the clients. And that ultimately improves their lives across the board, and their health care is embedded within that. Another success is allowed for opportunities of collaboration between RAIN and El Centro outside of UNC, and that is something that's going to be sustained once our side of the research ends. That El Centro has just celebrated their 16th year of LGBTQ support groups, and it's working with RAIN to build up LGBTQ support groups in Charlotte, because that doesn't exist in Charlotte, because Charlotte doesn't have an LGBTQ center. And so that is a success that we could not predict would happen, but that's the beauty of the collaborative model and working from two different sites, that they both have something to offer each other. And that also was part of the challenge, and I think that was very well addressed by the sites communicating amongst each other, that El Centro was sort of a community social support service agency, and RAIN is an HIV case management agency, which both worked in different ways. And so for El Centro, they had already the connection to the Latinx community. That existed, but providing HIV care support was very new and very different, and that proved to be a very big struggle. Some of the clients, after their diagnosis, refused to ever go back to El Centro for the fear of disclosure, and it didn't have to be anything specific, but this fear of the same reason clients will drive hours away from their home to receive health care at UNC versus a clinic along the way, because of this intense fear of stigma of outing yourself, of being discriminated against, of wanting that anonymity. And so that was very difficult to start talking about HIV care in the community in that sense, or at El Centro, or for some of our clients to feel cut off from the community in ways. So that is something we're still working around and trying to address going forward with El Centro is, okay, what do we do to address this? How do we fix this? How do we make it a safe space for everyone, regardless of your diagnosis, to continue to receive support services? What do we need to do as a community to address this stigma that is keeping people from walking in the door? And for RAIN, they're very new to the Latinx community. And so our navigator and our outreach individual were the first people on staff that were providing services specifically for the community. So that was very new. And so we had to do all the work to make the connections to the community. And so those were two very different models, two very different structures of organizations, which both had their positives and their sort of challenges. But also amongst each other, they were able to have those conversations. The staff at RAIN talk to the staff at El Centro. They're one big family, really, when they're all together. And so they could call up each other and have these conversations as to, doing outreach or talking about HIV care with their individuals, talking about diagnosis. And they were able to work really well with each other outside of us, which is huge, which is what we want. And so that was, an incredible success. And also just in general in terms of HRSA requirements, this country of origin criteria to enroll individuals was very, very difficult because we know that we have a lack of services for the Latinx community in general across the board in healthcare, but especially for HIV. So here's something we can finally offer the community, but we're restricted to country of origin. And we understand the reasoning. We understand that we want to be very intentional about cultural specificity about not lumping in the entire Latinx community into one, and wanting to be very thoughtful about the differences between people of different countries. But that also is very, very restrictive and was difficult to navigate because there are other individuals who are Latinx and didn't qualify. And what do you do? At RAIN, we were very lucky that they were able to still bring them into their HIV case management agency, still offer them services, though they couldn't enroll in the LASES program. And here in the Triangle, our navigator was able to refer them to different case managers, different clinics, and do some of the initial work of connection to care, but couldn't enroll them in the program. And so that was, restrictive and very difficult, and we'd like to see it expand. And at RAIN, because the program is so successful, is going to be offering it in the future to all people of Latinx background, which is really wonderful. And another thing we found was that because of these two different models of one being an HIV case management agency, one being a Latinx community organization, that each was successful in enrolling or recruiting either newly diagnosed or out of care. And so at RAIN, because they had already these connections with clinics, with providers, they could enroll newly diagnosed very well. They had a really great connection with the disease intervention specialist, and so newly diagnosed was a pretty efficient referral system for them. So most of their clients are newly diagnosed, and it's the opposite in sort of Raleigh, Durham, Chapel Hill, where we did more of the out-of-care lists, worked with providers to re-engage individuals, and didn't have as strong of a relationship with DIS because there's been a lot of turnover in this area. So those were two different ways we had to approach recruitment and enrollment depending on the site. Next slide. And so here I just want to give Lisa and I a chance to just talk more sort of, informally about our experiences with the intervention. What does this look like at this, community-based collaboration, and offer some insight and perspective for people out there interested in pursuing something like this. And so I'll turn it over to Lisa, and she can kind of share, what it's been like to be both, the researcher behind this, but also a provider to some of our clients and what that's been like for her.
Thank you, Joaquín. And I just want to make sure we save enough time in case there are questions, so I'll be pretty brief. So, I think Joaquín really summarized a lot of work that went into just the designing of the intervention. So, what you're sort of seeing on these slides was, over a year of sort of conceptualizing and creating and kind of trying to see what was out there in terms of programs for this population. And, while there are, certainly evidence-based interventions, around engagement in care and retention in care, they're really, when you start to drill down around, for Latino populations, particularly Latino MSM, Latino trans women, when you start trying to include linkage and retention in care, you really start to dwindle down to a non-existent number of interventions that really sort of meet all of those criteria. Which doesn't mean that there aren't intervention components that are really important that should be used, but it just means that we sort of try to think about kind of what are sort of the important ingredients that we can be sort of used that's already been developed, and what are some other novel things that we need to consider. And so all of that sort of went into the design of Enlaces. And I think as Joaquín said, we really focused on HIV self-management. There's been sort of a lot of move towards the importance of that as HIV has shifted from an acute kind of life-ending infection to a chronic disease with multiple sort of comorbidities, and the importance of sort of long-term engagement in care, but also the recognition that as people live longer lives, they actually have lives to live, and that involves relationships and disclosure and families and support and jobs and sex and all of the things that are really important in all of our lives are just as important in the lives of our patients. And so we took the approach to focus on self-management, of which HIV medication adherence and retention in care is obviously a huge part of. So I think, again, just, from my perspective, Enlaces was a lot of really important grant and sort of work and really eye-opening in terms of working with community partners in a more, in a true collaborative, I think, relationship. And I know that sometimes I think researchers kind of think about their community partners as sort of the place to sort of recruit and get the participants for the intervention. But we really, the community partners were involved in every step of intervention creation, testing. As Joaquín said, we went through, we role-played, we did the intervention, we changed wording based on sort of the PHNs practicing. They sort of ran with it. We had calls weekly where they came up with ideas for ways to sort of modify sessions that weren't working. We really did sort of continue to sort of modify as we went along. If there was places that didn't work, if they had ideas to find new clients, we really worked together. And I think that certainly the evidence of that is that at least at RAIN, they'll are going to sustain this program, as sort of a part of their community-based organization, which again I think speaks to the fact that this wasn't sort of a research study. This was about finding an innovative way to reach the population and keep them in care. So I think we've got about 10 minutes. So I'd love to, if there are questions, Joaquín and I can talk forever, but and I think Joaquín is doing another one of these tomorrow with our PHNs, which they will be much more interesting than I am as a co-host, and I would definitely encourage you to come and talk with them because they're fabulous and really have a lot of insight into working with the population.
Great, thank you both. And so we have a question in our chat function. It reads, did you learn anything about whom is more likely for falling out of care and/or what helps set patients up for successful care?
Yeah, it's a great question, and that's exactly part of what we need to find out. So, I'll just sort of give you sort of a sneak peek. Is that we ended up enrolling 91 folks. Our target was 100, so we were pretty close, and and we really worked hard to get that 91. We about half and half of our population were enrolled were newly diagnosed versus out of care. About a half split between the two community-based organizations. So again, I think we really have a rich data set. It's not thousands. So I think there will be sort of two different evaluations. One will be kind of our local evaluation. So we will start to look at that data. And to be honest, we actually don't have even access to our full baseline data set currently. Because this is a multi-site study, there's an evaluation center, and they hold our data currently, which I bug them about pretty frequently. And so we will have baseline surveys. We'll have medical chart data and abstractions for up to 18 months. And then we have follow-up surveys at 6 months, 12 months, and 18 months for folks that were enrolled for a full 18 months. We stopped enrollment with 1 year of follow-up, so we'll probably actually look at sort of the 12-month follow-up as our main outcome. So I don't have that data, but that is sort of part of what we'll be looking at is sort of different predictors of engagement and retention, new to care, out of care, and then also things, we do have a lot of measures in our survey, which I'm really excited to sort of start to dive into around stigma, sort of around sort of race or ethnicity-based stigma, but also around medical stigma in terms of engaging with the healthcare system and talking with providers, as well as internalized homonegativity for those that identify as MSM, and for those that are transgender, which again, we don't have a whole lot, but I think, that we have to, this is a really important population that we need to really start to dive into understanding their needs and any differences. So that was a lot of words to say, more to come. And I'm, again, I'm hopeful that in the next year we'll really be able to start to sort of really get some good data out about this population. The last thing I would say is, as Joaquín said, that there's 10 total demonstration sites around the country. All have different interventions, so it is sort of hard to say a lot about, there are some similarities, but they're all different. They're different locations, but there will be some ways that we start to combine data across the country to have sort of more insight into populations that are either Mexican or Puerto Rican, because we were, again, as Joaquín said, we had to sort of pick a country of origin.
And I think that'll be a great question if you're on tomorrow, that we can address with the navigators, at least from an anecdotal perspective, as to what their experiences were like. And from what I know from working so closely with them is that our newly diagnosed definitely have higher retention rates, I would say, than our re-engaged or out of care, and largely because the people who are re-engaging in care still have a lot of the structural barriers that they're working through. And so it's much more difficult to engage them and continue to keep them in care. And for newly diagnosed, a lot of them, that quick engagement with care, that very intensive connection with a support person with our navigators was very crucial and very successful. So it would be interesting to see amongst just the newly diagnosed what did work, what were the differences, since they all had a quick connection to care in that sense. I think, and I would say just from like a personal perspective, again, like without data, but anecdotally, that I think for individuals who are gay or bisexual or have sex with men, that people who were out, who had support systems in their lives, who were out to their family or to their friends, whether that was here or back home or either one of them or both, had an easier time engaging in care. I think for some of them, being able to talk about HIV and sexuality was very, very difficult and carries a lot of stigma and shame and burden that very much impacted their ability to, actively engage in their care. And that'll be something we can delve more into with these like stigma scales and questions in our data. But that is what I've seen personally and from conversations with navigators.
Great, thank you. I'd like to open to see if anyone on the phone has any questions. There's one question in the chat, but I'd like to give a chance in case someone had a question they wanted to ask sort of live. All right, well, I'll ask the question that's in our chat function. It says, can you talk about the Enlaces domain and careware and how that works?
Yeah, so that took a lot of legwork, a lot of multiple conversations with the state staff who sort of run the careware program. So we do have a person on staff who works as an epidemiologist with the state, and she worked, partially with us, partially with the state, and it was really that bridge, and that was very vital to having that connection, though it still took a lot of legwork, lots of conversations, but eventually we're able to basically, one of the state staff was able to build this domain or this sort of location that you could access in careware with our own sort of password, private access, where then we're able to add in all of our Enlaces clients, either if they were already in careware, which is to sort of duplicate and switch over to the Enlaces domain, or add them manually if they weren't already in careware, and that was dependent on what kind of services they were receiving, very much like Ryan White and that sort of thing. And then so they're all housed, and that's like one location you have to go to. So if any of their other records are updated in careware, they're automatically updated in our Enlaces domain. You don't have to sort of search for them every single time. And I don't have much more insight into that because I was very much on the outside of those conversations and work. But I know it took a very long time to get that done. We're still sort of working through that, especially because our clients see, I think, around 11 different, or go to 11 different clinics, and not all of them actively use CareWare. Not all of them are putting updates. Some of our clients have received care under different names. And so that's still very much a work in progress, and we have to do a lot of hand abstraction of medical data to manually input into our domain as well. But working with a state-level staff who has it was what was necessary, and lots of bugging and questions and persistence.
Great, thank you. I think we have time for maybe one more question, so I'll give a chance here, but if not, it looks like a question in our chat function says, do you have any examples of if people were able to garner social support or disclose with the help from their navigators? So I think you talked a little bit about, the role playing in scenarios. Can you share maybe an example of how that went?
Yeah, definitely. And so what the conversation kind of looked like within the session structure that we developed, and then what it looked like in practice was sort of an activity. It was, if you want to disclose, you kind of identify who you want to disclose to. You work through a series of questions. What time, sort of where does it feel safe? What are your reasons for disclosing? What do you predict the outcome could be? And all sorts of options. Like, so what happens after if they don't take it well, if they do, and sort of walking through all of that, and sort of the navigator would play the role of this individual and sort of talk through these things. And so the client got to kind of practice how they were going to disclose, what kind of language they wanted to use, and go over that multiple times, and also kind of go through the potential different reactions they're going to receive on the navigator would kind of play that role. And so we did have quite a few clients go through that and actually disclose. And so we did say this one was partially successful, but I'll talk about another successful one. But just interesting though, so one of our clients, his father had HIV and died from it. And so he wanted to tell his mom, was very scared because he felt like, his father died from it. He didn't want his mom to worry about him, even though he was in care. And, he also was not out to his mom as gay. And so he first was like, okay, first I'm going to come out to her as gay. So they practiced coming out, disclosing his sexuality to his mom first. So he did, and she took that well. She's like, I love you, nothing changes. And she says, just don't get HIV. And so he kind of laughed, when he's telling this to the navigator was, well, now I know that conversation's not going to happen. He did feel better that he was able to come out to his mom, but that was a partial success. But that was sort of something he could walk through also with the navigator. That was also regards to sexuality, not just HIV, but about disclosing your full self. We did have another client who, again, mom seemed to play a very big role in our clients' lives. Definitely familiar with that myself. But one of our clients was very close to his mom. She was still in Mexico. They would call each other every single Sunday. So after his diagnosis, he started to sort of distance himself because he felt he didn't want to tell her, again, didn't want her to worry, but they stopped talking. Like the gaps got larger and larger between conversations, and so he felt very bad because he didn't want to distance himself from his mom and worry his mom that way. So he's like, I need to have this conversation, get it over with, and he was able to, and she was very supportive and just said, asked questions like, what does that mean? Are you receiving medical care and that sort of thing? But she took it very well, and he's been able to go back to having these weekly conversations with his mom and not have this hanging over him, not have this put distance between himself and his mom. And so that was, again, another way they were able to sort of walk through, what does this look like? What are the different reactions? How will you react to these reactions? And that one was the
Aim Simmons.
Left.
And so,
hello? Okay.
Yeah.
So we're still on the line. So we're right at 3 o'clock, and I know we have some additional questions in our chat function. So what I will do is I will save those, and as sort of a ready to get those answers tomorrow, but I do want to invite everyone to join us tomorrow for part 2 of this webinar where we will hear from the perspectives from the organizations that participated in this. If you are interested in sharing some of your own research that would be spotlighted in our series, you can send me a message. But again, I want to thank everyone, and I want to thank our presenters today for participating and sharing all of this amazing work that is being done here in North Carolina. So thank you both.
Thank you, guys.
Thanks,
Thank
everyone.
You. All right.
Thank you.
Bye.
Bye.
Left. Left.
Joaquín.
Left.